2. I want to welcome everybody to healthyseminars.com. My name is Lauren Brown. I'm your moderator today. I'm also a doctor of traditional Chinese medicine. I practice in Columbia, Canada at AcuBalance Wellness Center. And at Healthy Seminars, during this time of isolation, since March 24th, we've been putting out a series of lectures and just a lot of free resources for our community. So I'm so glad to see so many of you coming out and continue to come out. I'm just going to share a little bit of housekeeping before I pass it on to Dr. Thomas Bayne. We've created a page called Resources for you guys. And so I just want to let you know that you have the topical areas here. And so, for example, we created a whole COVID section as well, TCM knowledge and COVID. So that's where you can find this lecture and the replay as well. And then we have a list of what's coming up here for dates. So we got lots of fun things in our dates here. Do check out, we keep adding something every day. Like we just added, Lillian Bridges is going to do a new forecast, revisiting the Year of the Rat forecast based on what's going on. So she has stuff to share. So I just want to let you know that that's how you can find this stuff. Lauren, I thought I heard something. Is that so good? Okay. So just to let you know, for this material, if you want to revisit this again, if you click on this, it takes you right there. And then here we are for Thomas's thing, and this will have a replay later. And so when you go back and you want to see what's going on, this is where you'll find all this extra information. Our goal again at Healthy Seminars during this time, if you look at our logo up here, is community, unity, immunity. So we've been creating and offering this event because we want community. And this is how come your cameras are on. And at the end of this, we open up our mics after the Q&A so you can kind of send your love and appreciation to the speaker and also connect to each other. Because although we're having physical distancing, we're still allowed to have social solidarity. And so this is our chance to be together, and hence community, unity, immunity. Now I got to share with you about Tom and this talk today. So originally I was going to be seeing Tom and hearing Tom talk about gut health and fertility at the Integrated Fertility Symposium. So Megaspore has been an exhibitor and sponsor and supporter of the Integrated Fertility Symposium for all of our years, and we had to cancel it. So I was just doing my connecting with my exhibitors, saying, "Yeah, we've canceled. Sorry about that, etc. Maybe next time." And Tom and I were geeking out, and Tom was talking and about inflammation, the cytokines, and he was talking about the immune system and about, if it's underactive or overactive and leaky gut. And we're just having a really cool conversation. And this is how this webinar comes about. But during the conversation, I said, Tom, I'm sorry about the IFS, but I'm going to, there's some opportunities we can try and do, but I'm prepared and ready to refund you. And he goes, "Oh, I'm not taking my money back." He goes, "We're okay. No, I want to support the IFS. You're not ready the refund." So I said, "Well, thanks, but that's not how I roll. If I can't give you something of value, I need to give you a refund." So we came up with the idea of him sponsoring a webinar. So I wanted him to share this content, and now he's using his IFS money, and he just said, "Okay, then that's why I'm going to sponsor this event." So usually the webinars, they're all free to you guys, and we just put them on free for us. But I just want to let you know the kind of company and the person Tom is. Tom just said, "Well, I want to do a webinar for you guys, and let's call it, I sponsored your webinar. So just don't give me my money back." So I just want to say thank you, Tom. And I'm glad we're going to be able to give you value. And I'm glad you're going to give all the participants value. So our talk today is on the virus that we say can't be named, because Facebook or YouTube will take you down if it's not to their liking. It's about preventing the cytokine storm. And I will share on Healthy Seminars, we've been doing our best to not talk about how to treat, because that's not our expertise. We're not bringing in people to do that. We're bringing in people that will share information with you to support your body so it can adapt to respond to its environment, no matter what is out there, whatever bacteria, whatever virus, whatever name it is, whatever stressor, that your immune system is at tip-top shape so it can have a good relationship or ability to adapt and respond, so you can work your way through whatever condition you are experiencing. And so that's what Tom said he was going to deliver for us as well. Tom, by the way, his background, he's a chiropractor, doctor of chiropractic, and he founded the the Microbiome Lab and the Megascore company. And so really glad to have you guys here today. I've heard Tom speak on several occasions at conferences around the world when we've been at conferences together. And I've heard him speak at the Integrated Fertility Symposium. So I'm very glad that we're going to get to do that again today. Tom, I'll get you to bring up your point now. And I just want to share a final disclaimer for you guys is that you can let Tom bring up his PowerPoint. Our disclaimer is here, and it basically states that this is for educational purposes only. This is not medical advice. This should not be received or intended to be medical advice. If you have a health condition, please seek out a healthcare provider. Again, this is for educational purposes only. All right, Tom, without any, I love it when you teach. I'm looking forward to hearing what you have to share. It's your show, take it away. And everybody stick around at the end, raise your hand digitally, and you'll be able to have discussion and questions with Dr. Tom Bayne at the end of this webinar.
Thank you, Lauren. It's a pleasure being here. I appreciate all the kind words you've said about me, and I hope I can offer some value here for everybody and pass a little bit of time with some good information here. So I'm going to address our present viral situation in a slightly different way than many people are approaching it right now. It seems to be everybody's has a very much an antivirus approach to how they deal with the situation. And I'm not here to badmouth anybody's approach to this. I think we're each learning things every day. This presentation is to the best of my knowledge today. I reserve the right to change my mind tomorrow if there's new data out there. But I try to bring some of the latest information, also some of the latest findings that I'm having with some of my patients that happen to be struggling with the virus right now. So we'll get into it, and like I said, hold your questions, or add them to the question box, and but I'm happy to answer all of them. If I can't get to all the questions at the end, then Lauren will forward those to me, and I'll make sure to get an answer to you guys via email or something like that. So let's get started. So here we are, people, right? Whole new world, COVID-19 pandemic. So I'm going to take a slightly different approach to this, and I want you guys to first, let's kind of look at the theory and the treatments with the coronavirus. So right now, it's being treated as an infection or a disease dysfunction of the lower respiratory tract. So that's the approach, and the primary symptoms include a fever, cough, shortness of breath, and mild cases seem to run their course. Lots of information out there about the number of carriers might be bigger than we initially have thought, that there may be a lot of people that are asymptomatic. We're getting huge numbers of people that have mild reactions to it. And so it's but then there's the other people, and these are the ones that we're seeing on the nightly news and everything else. And it's a relatively small group of people, but these are the people that the disease reaches a critical level, and we see severe hypoxemia, which leads to tissue and organ shutdown and eventually death. So why is this? Why is this happening? So the current allopathic treatment is the use of antiviral therapies. There's some good data on the remdesivir, and the HIV cocktail has shown some benefits. The issue with these treatments is their costs. They're very expensive therapies. There's also interleukin-6 inhibitors and Janus kinase inhibitors. Those come with a slew of side effects and also big ticket. So hyperimmune globulin from the plasma of people who've recovered from COVID-19 seems like a really cool opportunity for a new way to treat this. But studies are just getting underway right now, and it's also going to have a pretty high price tag to go with it also. So as patients go through this process and these remedies fail, ventilation becomes a last resort. And so ventilation is based on the assumption that the virus is causing a fluid buildup at the alveoli. Well, this obviously makes it difficult for oxygen to pass through the fluid and into the bloodstream. So This assumption is based on the presentation of patients with acute respiratory distress syndrome. And mechanical ventilation is the way that they force air into the alveoli. The only problem is that what we're seeing with the COVID-19 patients is that ventilation is not working. Actually, many doctors believe that it's doing more harm than good, definitely in specific cases. So what do we know? So what we know is that some patients, the blood oxygen is so low that you would assume that there would be obvious signs of distress on their face, that their breathing would be labored, that the patient would be gasping and panicking because they can't breathe. Yet that's not what we're seeing. We're not seeing any kind of lung distress in these patients, even at end stage. We're seeing oxygen saturation is very low. We're seeing that oxygen and carbon dioxide exchange comes to a halt, causing a ground glass appearance in the lungs on X-ray. We're seeing that many patients lose their sense of taste and smell. And what's interesting about this is that many patients can actually point to the moment when they lost their sense of taste and smell. It's that profound, and it happens that quickly. Patients with worsening symptoms present with elevated cytokines, and as their condition worsens, these cytokine levels show to be increasing over time. And this is what we're going to be focusing on a little bit with our conversation today. So oxygen carrying capacity. So in COVID-19's final stages, it looks like respiratory failure, and there is tissue damage to the lungs, but the tissue damage to the lungs is the result of oxidative stress. And the oxidative stress is blocking the ability of hemoglobin to carry oxygen to tissues. We're actually getting iron being kicked off of the red blood cell and into this circulation. And so there's no means for the red blood cell to carry oxygen. So the reactive oxygen species cause hypoxia. They damage the red blood cells and all the tissues they come in contact with. The ventilators force air into the lungs. So this is beneficial if fluids or inflammation in the lungs is the problem and the blood is working fine. But if the blood's not working well, if the red blood cell's been damaged by the reactive oxygen species and the red blood cell can't carry oxygen, then forcing more air into the alveoli or into the lungs is not correcting the underlying problem. So there isn't a problem with the lungs getting oxygen in the blood. The problem is that the red blood cells can't get oxygen in the tissues. That's why we don't see the patient gasping for air. The lungs are working, the oxygen is just not getting to its final destination. So here's a graph showing the early stage fatality rates by health conditions in China. And so you see that cardiovascular disease patients have 10.5% of them that contract the virus die. Diabetes, chronic respiratory disease, hypertension, cancer. And so this is from China. Here's the ones from the US. In the US, the three largest groups with the highest mortality rates were diabetics, people with hypertension, and people with cardiovascular disease. So what do these conditions have in common? And we'll touch on all the conditions that we talked about, but what is the commonality here? And that's going to be the interesting part of this story because it has to do with the cytokine theory. So the idea is that there are pre-existing conditions that are associated with elevated inflammatory cytokines. And this makes it easier and faster for the cytokine storm to spread rapidly throughout the body. So the pre-existing fires cause tissue damage. The existing inflammation as a result of that is magnified by the cytokine production from the virus. So when the inflammation from the virus kicks in, the fire spreads rapidly throughout the body, taking every organ system with it as it goes. And then the organ systems that are most damaged from the daily cytokine damage are the organs that go first. So let's take a look for a second at inflammatory cytokines and their role in chronic disease. So here's some studies showing the effects of cytokines in hypertension. Here's studies showing it in cardiovascular disease. And here's studies showing inflammatory cytokines in diabetes and the role that they play in the complications of diabetes. And so there's our top three in the US. We've already shown the connection between the condition itself and the existence of cytokines. And now when these patients are presented with the virus and the cytokine reaction begins, it runs out of control because of this pre-existing level of cytokines that are already in play, if you will. So what's the number one cause of low-grade inflammation due to excessive production of inflammatory cytokines? You may be asking yourself. Well, it's something we're very familiar with, something called leaky gut. So if you look at the diagram on the left, what we're seeing is a healthy gut. And so on the top of the diagram, you're seeing what is the microbiota. And in this picture, it's represented by healthy, diverse microbiota. You then see the blue shaded area, and that's the mucin layer. That serves as a buffer to push the microbiome off of the epithelial surface. And then we see the worm-like structure in about the middle. That's the epithelial layer, the single cell layer. And we see that the junctions between them are all tightly closed. And then below the epithelial layer, we see the basolateral circulation. So if we shift to the picture off to the right, what we get is we get dysfunction, dysbiosis in the microbiome. We get an overabundance of mucus-degrading, toxin-producing pathogens that eat away at the mucin layer. As the mucin layer starts to be degraded and starts to disappear, now the microbiome starts to lay right on the epithelial surface. This immediately causes a reaction by your immune system. And this is the reaction that is intended by our bodies to stop septicemia. It's the process of blocking bacteria from getting into our bloodstream. And so what happens is that the bacteria and the bacterial byproducts start to degrade into the mucin layer, create the inflammation in the epithelial layer, start to break through the tight junctions, create holes. And then the circulating LPS, which is a normal occurring variant in our microbiome, when that LPS seeps into our bloodstream, it gets tagged by our macrophages, and then the cytokine cascade starts the production of interleukin-6, tumor necrosis factor alpha, interleukin-1 beta. That process starts, which eventually leads to inflammation. So this is the underlying cytokine storm that causes the ensuing production of cytokines from the virus to burn out of control through our body rapidly. And so what is metabolic endotoxemia? Metabolic endotoxemia is a fancy name for leaky gut. It's essentially the innate immune response that creates a subclinical persistent low-grade inflammation in response to the circulating endotoxins that get into the basolateral circulation. So it's estimated to affect approximately 50% of the Western population. In the studies we've done, we showed that 55% of healthy adults that we screened showed to have metabolic endotoxemia. The condition is characterized by an increased serum endotoxin, lipopolysaccharide, during the first 5 hours after a meal. So what is lipopolysaccharide? So real quick, lipopolysaccharide is a normal part of the outer membrane of gram-negative bacteria. When those gram-negative bacteria die, whether it's for normal reasons or antibiotic use or whatever, so when those bacteria in our microbiome die, they lyse and they release this LPS. Under normal conditions, the LPS just becomes part of the stool and it's eliminated. When it seeps into the bloodstream is when we get the reaction that we'll go through here and explain that. So meals that are high in fat and dense in calories seem to impact the condition more than low fat and low calorie meals. With this increase in serum endotoxin, we see a reciprocal increase in the cytokines, interleukin-6, interleukin-1 beta, interferon gamma. We also see an increase in triglycerides and and postprandial insulin. So chronic metabolic endotoxemia and its associated inflammation has been shown to have significant correlation and increases in the risk of developing a variety of chronic diseases, including cardiovascular disease, diabetes, obesity, hypogonadism, every autoimmune disease that we know of, and even mood disorders like anxiety and depression. So let's look at how this works within our immune system. So toll-like receptor 4 is an important signaling protein associated with our innate immune system. It's found on the surface of innate immune defense cells like our macrophages and dendritic cells. So the circulating LPS gets bound to a transfer protein called LPS binding protein. So this binding protein carries the LPS to the CD14 toll-like receptor complex and says, look what I brought you. And so this is how our immune system is able to react to the things that our immune system encounters in our bloodstream. So once the LPS and LPS binding protein is bound to the CD14 toll-like receptor complex, it initiates an immediate immune cascade that leads to the activation of NF-kappa B, which then leads to the increased expression of the pro-inflammatory cytokines, tumor necrosis factor alpha, interleukin-1 beta, interleukin-6, and MCP-1. So the innate immune cells that become activated by LPS and subsequently cause the chronic release of these cytokines, they exist in every aspect of our body, including the blood-brain barrier. So what are some of the clinical manifestations of LPS-induced chronic immune activation? Well, if you remember, our main symptoms or the main comorbidities that we discussed, heart disease, hypertension, and type 2 diabetes were big ones. But we've got a slew of health conditions that either as part of their pathophysiology, this spilling of LPS into the bloodstream and the reciprocal production of the cytokines in response to that is either the cause or part of the pathophysiology of all of these conditions, right? So it's a big aspect of what's driving many of these conditions. So you'll see that in some of the future slides, the progression of these conditions is dependent on an increasing concentration of these poisons in our bloodstream after each time that we eat. So stopping them is a good way to start reversing some of these processes. So this is a quick study I wanted to show you guys. This is from the American Diabetes Association. And I want you to look at the graph on the left. And so there's 4 groups of people. And what we're looking at is the circulating amounts of endotoxins in their blood after a meal. So they start out fasting and everybody's pretty normal. And then it goes 1 hour, 2 hours, 3 hours, 4 hours across the bottom. And so the groups of people that we have are normals. We have people that are obese. We have people that have hyperglycemia, and we have people that are type 2 diabetics, right? And so what we see is that at the 4-hour mark, we see that the normal people have the lowest endotoxic response. We see that the hyperglycemic and the obese people have an elevated endotoxic response. But look at the diabetic, right? So the diabetic is more than double normal, but the diabetic is actually double what the hyperglycemic, the pre-diabetic is. It's double what the obese patient is. And this is an interesting study because the conclusion of this was that they felt that measuring LPS in the blood was the best predictor of someone going from hyperglycemia to type 2 diabetes. So the LPS that's triggering the cytokine inflammation in their body is the number one driver to take somebody from hyperglycemia to type 2 diabetes. So this is another interesting study. So this study showed that when the LPS spilled into the blood, that it moves throughout the body and it creates a very specific type of cytokine response at the hypothalamus. And this specific cytokine imbalance creates essentially a diabetic presentation in patients who aren't overweight, right? So when I first started practicing, I didn't know there was such thing as a skinny diabetic, type 2 diabetic. Now we're seeing more and more of them, and that's because of this LPS-induced injury to the hypothalamus. That's the cause of why they're insulin resistant. This is another interesting study. So this study actually shows that the LPS from our gut that's not supposed to be in our bloodstream actually makes its way across our blood-brain barrier into our brain, and it creates a cytokine cascade of inflammation in our brain that's responsible for the lesions of the Alzheimer's brain. Here's another study showing that LPS is the #1 marker for cachexia in cancer patients. That this is what's driving the cachexia. It's the elevated levels of LPS. Now, I didn't forget what we're talking about, people, right? I know what we're here about. We're talking about the COVID-19 virus. So why am I talking about diabetes and all these other things? Because these are the people that are dying. These are the people that have the highest, that have these comorbidities, and the comorbidities are already presenting them in an extremely inflammatory state. And when the inflammation from the virus kicks in, it pushes them over the edge. And so these are the patients that are filling our hospitals, our nursing homes, and they have no defense because they're already halfway there. There's already so much inflammation in their bodies to begin with that if we turn on the spigot associated with the virus, they can't manage it. And so that makes sense, right? With these are those comorbidities. That's an obvious thing. But take a look at all of the conditions that are associated with the spilling of LPS into our basolateral circulation and the reciprocal cytokine inflammation that happens as a result. And so I know that there's people out there that have been touched personally by this condition. And so what I'm about to say might sound harsh and inhumane. I don't mean it to sound that way. I don't believe that anyone that dies from this condition was healthy. I don't believe that. I don't believe that there's data that proves that. All of these different conditions are associated with LPS and the reciprocal inflammation that goes along with it. They may not physically look sick. They may not even present with symptoms, but the underlying inflammation is there. And until data proves me wrong, I will fight for that. I will stand strong with that opinion that, even though they were an athlete and even though they looked healthy, there had to be an underlying reason for them to have an excessive amount of inflammatory cytokines that when they got the virus took over and proved to be fatal for them. So I'm not pointing the finger at the dead and blaming them. That's not what I'm doing. I'm trying to take the information that's in front of us and with a critical eye understand what we're looking at. LPS and the underlying cytokine inflammation is a worldwide problem, and it impacts billions of people on planet Earth. And so some of them are exhibiting symptoms, some of them are not, but it's there. And until proven otherwise, I feel that this is the initiation of the difference between somebody who does fine, gets the virus, and in a week or so they're better, versus somebody that doesn't. So this is a study that showed that stress-induced endotoxemia was really the cause of chronic non-communicable diseases, which is the leading cause of work absence around the world. And it's associated with a low-grade inflammation. So this study goes another step, because now we're not even saying that you have to have a diagnosable condition to have this LPS in your system. This shows that non-communicable diseases are the number one reason for them is this LPS-induced inflammation. So many of the people, almost everybody walking planet Earth has some variation or some level of this endotoxemia and this level of inflammation. We feel that it's ground zero for just about every health disorder that we know. So here's another interesting link between metabolic endotoxemia and poor outcomes due to the coronavirus. It's the ACE2 receptors. So COVID-19 and other coronaviruses, they bind and attach to open ACE2 receptors. So the ACE2 receptors remain available for viruses to attach to when the enzyme production is low or impaired. Now that can happen with smoking and pollution. That's one of the things. And there are some genetic disorders associated with low ACE2 enzyme production. And so ACE2 receptors are open when there's systemic inflammation and when that inflammation is not being addressed. LPS drives low-grade systemic inflammation as well as localized inflammation, and it can impair ACE2 enzyme production, leading to lung inflammation. Therefore, chronic metabolic endotoxemia, leaky gut, and the resulting inflammatory cytokine reaction weaken the immune response of the lungs, making it more susceptible to viral infection. So, my approach to this is a comprehensive approach. I have to address the acute nature of the virus, but I also have to address the chronic nature of the underlying inflammation. And so let's go through that. So treatment protocol should address the virus damaged oxygen carrying capacity of the red blood cells, the buildup of reactive oxygen species, and the chronic underlying endotoxemia. This is what we know, okay? We know it's a virus. We know that the oxygen carrying capacity of red blood cells is damaged. We know there's reactive oxygen species, and we know there's underlying endotoxemia. So if we're not addressing all of those things, we're not doing a complete job. So step one, cut the head off the snake. This virus hides in our sinuses, the eustachian tubes, and the throat. It does this to escape detection from your immune system. And so to treat this, I've been very effectively, I might say, using nebulized hydrogen peroxide. It must be food grade. I know that there's information out on the website, out on the in the internet universe that says that you can use store-bought hydrogen peroxide. I don't prescribe to that. And the reason I don't is because I know that in the US, I can't speak for all you Canadians and the rest of you and the rest of the world, but I know in the US that in products like hydrogen peroxide, if there's a less than a 5% amount of garbage that they add to it, that it doesn't have to be put on the label. So I just don't trust that there's not some kind of toxic compound that's been added to hydrogen peroxide, especially when the ones that we buy in the store that aren't food grade say specifically not for consumption. So I just feel that it's not worth the risk to use non-food grade hydrogen peroxide. I know some people are saying that it is okay. I don't agree with that. I think maybe it is over concern. And maybe if I was sitting here with a dry cough and coronavirus and no food grade hydrogen peroxide, maybe I would resort to that. But stock up on some food grade hydrogen peroxide. Make sure that your family, friends, and patients have a supply in the event that they do get the virus. I also love Argentin. I've loved this for every virus I've ever used it on. I like it as a nasal spray. I like it as a throat spray, and I like it as an ear lavage. And I also love Biocidin throat spray. I think it's a phenomenal antimicrobial. It's a great immune system booster too. So this is my first approach is to cut the head off the snake by hitting it where it lives. So antiviral and immune modulating support. Now, I really didn't need this slide. I'm just kind of putting it on there. I know you guys have your go-to antiviral and immune modulating products that you use. I'm just going to hit this real fast and let you know what I'm using. I love loricidin, again, for every virus I've ever used it with. I do like it with this virus. I have seen some good results with it. I have had some people that was really the only antiviral they had in their possession when they got it. And, whether or not it was the loricidin or whether or not it was their own immune system, I don't know. But I give good credit to the loricidin. I like it a lot. It's a good product. I love olive leaf extract. Stinging nettle root's an interesting product. I use it mostly for allergies of the lung. But if you look at the data, there's some really interesting antiviral data with the root, and I have been using it. I have been recommending that my patients that have the virus take it. Tinospora is a Ayurvedic herb. It's really more the immune modulating capacity than antiviral, but I love that product. Great. Same with Chinese skullcap. Very good antiviral, very good immune modulator. And I'm a big fan of Epicor. Epicor is a yeast postbiotic. Very good research around immune modulating benefits. So these are the group of products that I use for this step of treatment. Reducing the oxidative stress from reactive oxygen species. I love high dose vitamin C. If you can't do IVs on people, find someone that can for your own use and to be able to refer for your patients. When people are slipping down that slope, IV vitamin C has proven itself. When hospitals are starting to use IV vitamin C, that the reactions that they're seeing are indisputable. In the meantime, for those that are either early in the virus, don't have access to IV, or for prevention, I like to use the liposomal C. I'll use 1 to 3 tablespoons of it a day preventatively, but I'll use it every 1 to 2 hours if we're treating the virus. C reduces the inflammation, cytokines. It slows the replication of the virus. But real specific to this condition, it binds to the iron that's been released from the red blood cells. And that's huge, because the iron itself eventually becomes part of the reactive oxygen species also. And so if we can bind to that and get it eliminated, that's going to lower that inflammatory situation. IV ozone, antiviral, immune modulating, and very good at reducing oxidative stress. Glutathione, big fan of glutathione when there's anything going on with the lungs. I love nebulized glutathione, especially in this case, because of the proximity of the damage being done to the lungs. If that's not available, which you should be able to get that, getting a nebulizer is as easy as going on Amazon. But in the event that you can't get the nebulized glutathione, then I would recommend liposomal glutathione. Glutathione is very difficult to absorb. That's the main problem with it. When you get it to absorb, it reduces inflammation and it modulates the immune response by reducing cytokines. Glutathione is one of the most important intercellular antioxidants. So it's really our body's main weapon against the reactive oxygen species. Hyperbaric oxygen therapy is really what these patients should be getting in place of ventilation. Forcing the oxygen into their bloodstream is the way to go, because the mechanics of ventilation come with its own group of problems, and in many cases becomes part of the problem. So hyperbaric drives oxygen into the bloodstream without having to be intubated and be something that's stressful to the patient. I also like inhaled hydrogen. I'll be honest with you. I've just started utilizing this. I'm new to this concept. I did read a couple of really interesting articles about it, and I have implemented it into my treatment protocol. but I would be lying if I was giving you information based on my experience with inhaled hydrogen. I have experience with all these other things. The inhaled hydrogen I put on here because, it may be something that you guys can get access to, and the evidence was good enough for me to add it to my program. Just want to give you full disclosure that I just don't have a lot of experience with it yet. So nutrient support, I like the bisglycinate form of zinc better than any of the others. It's just my own personal preference. But it has to be combined with either the ECGC from green tea or quercetin to improve its uptake. And that is the mechanism of action. More than likely, that's the mechanism of action of why the hydrochloroquinone medications work, is that they are zinc ionophore. They open up the pathways for the cells to be able to intracellularly take in zinc. And so quercetin and ECGC are natural forms of it. And it's, the doctors that are using the malaria medications, that's the whole idea of it, that it opens up the cells to be more receptive to zinc in the system. So zinc blocks viral replication. It modulates the cytokine response, and it acts as a powerful antioxidant. So I hit on this a little bit, but I'll say it again. As the red blood cells are damaged, how you have to think about it is like the red blood cells are a raft that carries oxygen, but the iron on the raft is what holds it in place. And so if the iron's kicked off the red blood cell, we have no way to transport the oxygen to the tissues. And so oftentimes as the cytokine storm is taking hold in the patient's body, what we're seeing is a fast dramatic loss of the senses of taste and smell, which is a telltale sign of zinc deficiency. So, you have to be careful with zinc. Zinc, selenium, and copper kind of go hand in hand with this. And so I believe it's very prudent to be careful with zinc in the prevention phase. But from what we're seeing in the treatment phase, it looks like the amount of zinc can really go a lot higher than what we would typically give to a patient as a daily dose. I'm seeing upwards of 150 milligrams. So I would be prudent with the use of zinc. If we've got patients that are not sick and they're loading up, taking 100 milligrams of zinc a day, then what we're going to see is imbalances in selenium, and an imbalance in selenium is going to make people more susceptible to viruses, which is what we're trying to prevent in the first place. So I can't understate the importance of zinc, but I think it should be handled with care because we don't want to overdo it, especially in the prevention stage. So that's the direct approach to the virus. Now I'm going to talk about my direct approach to the chronic underlying cytokines that are at the root of why the cytokine storm gets out of control. And that has to do with correcting the leaky gut. So this is a study. This is the only study to date that shows a product that can fix leaky gut in humans. So there's a lot of people out there saying they've got tools that can fix leaky gut, but there's only one product that's proved it in humans, and that's Megaspore Biotic. So what we did was we took healthy college students. They were between the ages of 18 and 33. They had no underlying health conditions. And we brought them into the lab fasting, and we fed them a high-fat, simple carbohydrate meal. And we observed the levels of endotoxins in their blood over time. So when you see this graph, you see at the 0, there's barely any LPS. And then at the 3-hour mark, we get a little uptick. And then at the 5-hour mark, we see 8 to 10-fold increase in the amount of circulating LPS in their bloodstream. So we sent them home. This is our model. We've proved that this patient has endotoxemia. And so we sent them home with a 30-day supply of the probiotic. We had them come back. We had them eat the same high-fat, high-caloric meal. The McDonald's breakfast is what we fed them, actually, if you want to know the truth. And so we fed them that same McDonald's breakfast, and we completely blunted the circulating endotoxins in their system. And so I'd love to be able to tell you that the mechanism for how this worked, but I don't know yet. I've got some theories. I don't know. Like the doctors always ask, well, did you seal up the tight junctions? Did you neutralize the LPS? I don't know. I think it's a combination of everything. But we're doing some work right now to understand mechanistically how this works, but we know it works because we can see it in this study. What we also saw, well, this was in the double-blind study. So in the double-blind study, the spore treatment group, we saw a 45% reduction in their endotoxins, but in the placebo group, we saw a 32% increase. So what this says to me is that the leaky gut is a progressive condition over time. And so we're actually in the process of repeating this study over 90 days to see if the gap actually increases the further out we go over time. This was only a 30-day study. And so we see a 60% reduction in endotoxins between the treated group and the non-treated group. But that's not all we saw. So we saw a reduction in ghrelin. Ghrelin's the hunger hormone. And so if you look at this graph, what you see is that the ones who took the probiotic have a normal ghrelin response to a 2,000 calorie meal. The patients who did not take the probiotic, their body is starving for nutrition, so it's as if they didn't eat. This is going to cause this person to be eating more frequently and gaining weight. So we also saw a very interesting thing. We saw a reduction in serum triglycerides. We also spun off this idea, and we did a separate study on patients with high triglycerides. That study was just accepted for publication and is going to be published sometime in the next 2 to 3 months. But we're consistently seeing that when we reduce the LPS and the cytokine storm associated with it, that we're able to reduce triglycerides. We're able to do that because in the reduction of LPS, we're taking a lot of the stress off the liver. And so when the liver's not stressed, it doesn't have to produce as much of the triglycerides to deal with the inflammation. So fascinating downstream effect of reducing LPS. So this is a heat map, okay? So follow me here. So there's a line going diagonally across the middle of your screen. Everything below that line did not meet statistical relevance. Everything above it did, okay? So what we're seeing is that on the right, we have the placebo group, and on the left, we see the spore treated group. And so what we were able to see is positive changes to the circulating levels of endotoxins. We knew that. We knew the triglycerides, we knew the ghrelin, but look at these next things. MCP1, IL-12, IL-1 beta, IL-6, and IL-8. Those are the inflammatory cytokines that we've been talking about. Those are the cytokines that burn out of control in patients with COVID-19 that is not being controlled, that is sliding down the slope towards eventual death. Now, there are other cytokines that are below that line that we saw nice trends and nice patterns, but we just didn't have a big enough group to reach statistical significance. We believe in the next study with more people and over a longer period of time that a lot more of these interleukins will become statistically relevant. So happy to share that information when it's available. So in conclusion, COVID-19 has changed our world. We need a multi-pronged approach for our patients. I believe that more and more of us are going to be seeing patients with this, right? So right now, it's hospitals and it's the frontline people that are seeing it. I can't speak for all of you, but I'm not a frontline person. That's not what my practice is. It's not what I've ever been. And so, but I believe that as we start to develop a group immunity to this, that more and more of us are going to see the early signs of this infection in our practices. And I think that we can do just as good a job because we're in the business of prevention. And if we take this multi-pronged approach to the early cases of this virus, I believe that we can keep it under control in many of, well, in all of the healthy patients, but in many of the people that are coming in that are already sick. So controlling the metabolic endotoxemia before the virus is ideal. If you can get to your patients then, that's the best way to prevent it. But you have to address it once the virus kicks in. So we know that metabolic endotoxemia is associated with all of the comorbidities that we're seeing. We know it's associated with people that are in nursing homes and in hospitals already. And so if we can address it with them right away as both prevention and treatment, it would be a good thing. So this endotoxemia affects the immune system and the endocrine system, leads to numerous different diseases that we've mentioned, but it's associated with the elevated cytokines and postprandial insulin and elevated triglycerides. Spore-based probiotics reduce the endotoxemia and the inflammatory cytokines associated with these diseases. And they also reduce the LPS and the associated cytokines. So what I'll do now is I will open this up to questions from you guys.
Thank you very much. So we're going to do some Q&A with Dr. Tom here. To raise your hand during this live webinar digitally, at the bottom of your laptop, there should be a raise hand option, and there should also be, or find it under participants. If you're on an iPad, I believe you hit the more button. We'll ask Dr. Tom where people can pick this up if they're outside the United States. Obviously, in the States, it's easy. Microbiome, the website, we're going to put it in the chat again, but it's microbiomelabs.com. In Canada, for our patients, we have a distributor, so we can get it to you in Canada in 3-month bulk options. And we're going to get you to raise your hand. So we got people with their hands up. Tom, if you're ready, I'm going to just start to, based on the order I get them. So Diane Carter, you should have mic rights.
Okay, I don't know if you can hear me or not. Do you think that Advil causes leaky gut? Because most people were taking Advil for the fever. I'm wondering if that's actually making them worse.
So the question was, is Advil causing leaky gut?
Yeah. Yes. Or making it worse at the time when the people are getting sick?
All of the above. Correct.
Okay.
So what you have, all the non-steroidal anti-inflammatories create inflammation at the epithelial lining. And if there is any early signs of leaky gut, it will make those worse. In a case where somebody does not have leaky gut, one dose of a non-steroidal anti-inflammatory is not going to cause a leaky gut. But the problem is we can't tell from person to person how many doses it's going to be before it causes the leaky gut. In some patients, it'll be one dose. In many patients, it won't be for a while. It'll need to be repetitive dosing before you see the signs of leaky gut. But recognize that, when we're talking about at least 55% of healthy adults having this, we have to be talking about upwards of 95, 99% of people that aren't healthy. And so in those patients, it's a catch-22. There are benefits to controlling fevers and things like that, but the use of non-steroidal anti-inflammatories, you have to err on the side of caution.
Thank you for that answer, and thank you, Diane.
Thank you.
next up is going to be all right, Jill, you should have mic rights.
Hi, I have a recently diagnosed celiac nephew, 9 years old, and they're working on obviously rebuilding gut health. He's not medicated, he is gluten-free. Would the Megaspore Biotic be an appropriate product for him and at half dose or what? Thanks.
Great question. So in animal studies, we've actually shown the ability to increase the villi, the height of the villi. So increase the area of absorption, which is where the celiac does all its damage, where the gluten molecule does all its damage in the celiac patient. And so yes, I've got case studies that I can share with you about this. But yes, we feel that better than any other probiotic, there's none that can reduce the inflammation like the spores do. And then on top of that, the likelihood that there's some increased growth of the villi is only going to help with the patient's ability to absorb nutrition. So yes, we feel that that's an excellent first step. So we use what we call total gut restoration. The total gut restoration program is 3 products. It's the Megaspore probiotic, it's the Mega prebiotic, and it's the Mega mucosal. And so the reason we do this is because of patients like what you're asking about. And so the probiotic is the first step that we do with patients. In the case of this being a child, it really doesn't matter. We have dosing that we recommend everybody follow, and that is a titration schedule. So we have people take 1 capsule every other day for a week, then 1 capsule a day for a week, and then 2 capsules. When we take 2 capsules, all dosing with 2 capsules is done at the same time. We don't split the capsules up different times of the day. We take it at the same time, and we take all supplementation of the probiotic is done with or after food, because we've shown at least a 20% increase in activity in the bugs when there's food in the small intestine when they become active. And so in the case of your, I think you said nephew, what we would say is, because he's 9, or he's, and if he's a celiac kid, he might be a little frail. There may be some, absorption issues of nutrition that have been kind of ongoing. So he might be a little bit of a lower immune system, might be a little bit frail. So I might say, let's start him with half a capsule every other day for a week, and let's see how he does. All we're looking at is mitigating uncomfortable symptoms, right? Uncomfortable symptoms, in my experience, happen about 15% of the time. Those symptoms are usually cramping, loose stool. If I put all the people that had negative symptoms in a group, 90% of them, it's manageable. It's like, well, I got a little bit of cramping, I got a little bit of a loose stool, it's not a big deal. Then I'm like, great, then fight through it, and in less than a week, it'll be gone. It's that small percentage of people who, they took a full dose and they're on their bathroom floor writhing around in pain because there's a lot of intestinal cramping. When you've got inflammatory bowel disease and your intestines go into a cramping episode, that hurts like hell. When you don't have that, you go into a cramping episode, it's cramps. It's not a big deal. So we do that because we can't really tell who's going to have that reaction. And so in a young child, I may recommend going to a lower dose right off the bat, to break up the capsule, do a half a capsule, whatever it might be. But here's the thing. I've got 9-month-olds on the full adult dose, and I've got 12-year-olds who can't tolerate more than 1 cap a day without getting a loose stool. So you have to be able to participate in what's happening with your patients. There is not one size fits all with this. And if you've got somebody who can't get past half a capsule every other day or something, they can't get to those dosing, that's when I start bringing in the other products. I put the probiotic to the side and I bring in the prebiotic and the mucosal support. So if I can, most of the time I can ramp them up on the probiotic, regardless of age, and then I can introduce the prebiotic and the mucosal repair. That's the comprehensive program that I would recommend for a celiac patient.
Okay.
If I can't get them to get up to the full dose of the probiotic, I'll introduce the prebiotic and the mucosal repair outside of giving the probiotic. I'll do that for a period of time, and then I'll bring the probiotic back in. And oftentimes that'll be enough for them then to tolerate the probiotic.
Great. Thank you.
You're welcome.
All right. And I want to remind on the in the chat, you want to have supervision, obviously, of a healthcare provider as well. So if it's complicated and a lot of symptoms, then work with your healthcare provider as well. I know this product is available both for the public and professionals, and people use it for prevention and just good health. However, if things are complicated, then you may want to work with somebody to help you titrate dose and work with products and supplements. Susan, I think I've unmuted you. No, I have not. Now you're unmuted. Susan.
Yeah, thank you. So you may have answered part of my question by your last answer, because I wanted to ask about butyrates in addition to and or in lieu of probiotic. And is that part of your either repair or prebiotic formula?
So the prebiotic formula is a precision prebiotic. It very specifically feeds the specific anaerobic bacteria that are high short chain fatty acid producers.
Okay.
That is one way. In our studies that we've done, we've actually shown that the probiotic by itself increases butyrate production, short chain fatty acid production.
Okay.
We've also done a pretty good deep dive on oral butyrate supplements, and they seem to be very difficult. Like probiotics, butyrate supplements have a hard time surviving through the gastric system and getting where they need to be. We feel that short chain fatty acid producing bacteria are keystone strains of the microbiome and are hugely important for reducing inflammation and maintaining a healthy balance in the microbiome. The spores recondition the bowel. They go in and they get rid of the bad guys, and then they create an environment that's conducive for the good guys to grow. So they're not making short chain fatty acids themselves. It's okay. That's not what they're doing, but they are creating an environment that's healthy for those anaerobic bacteria to increase in their numbers. And so from our perspective, the use of the probiotic and the prebiotic is the quickest and most impactful way to increase the butyrate levels in the colon. Now, that said, I do have a new product coming out. Probably now due to the COVID thing, it'll probably get pushed out till summer. But that is an anaerobic bacteria, and it is a Butyraccoccus. It is just a butyrate producer.
Okay.
I'm very excited about this. I do not have that product in my. I'm lying. I have the product in my hands, but I only have one bottle of it, and it's mine. So that won't be available until probably the beginning of the summer. But that will be another approach to butyrate. I just don't feel that oral butyrate supplementation is worth the expense, because I just you get such a minuscule amount of it that makes it to where it needs to be.
Thank you. Second part to your question, please. Is there a point at which one no longer needs to be taking a spore probiotic? I mean, that the microbiome has sort of repopulated and healed and can now work on its own? And if so, what would you look for, and what would that maintenance dose then look like?
So, great question. The act of eating causes metabolic endotoxemia. So until we figure out how to function without eating,
Okay.
being an issue. But let me explain how I address the maintenance issue. When the full dose of Megaspore is 2 capsules a day, and the reason we have you take it together at the same time is because it's a numbers game, right? So when we take half a capsule or 1 capsule, we're getting competitive exclusion of the spores, and we're getting nutrient production. But one of the main properties of the spores is to modulate the immune response. So bring it down when it's up and bring it up when it's down. And so
Like glutathione.
until we get to that second capsule of powder, we're not getting a high enough concentration of the spores in there to get the immune modulatory benefits of the spores. So when I have somebody where the conditions cleared up, they had something, they're fine, we've identified that their microbiome is in good condition and there's little to no inflammation, and we're deciding we're going to go to a maintenance dose, I keep it at 2 capsules a day still, because I still need all those benefits, but I supplement it weekly instead of daily. So I'll say to patients, even people who eat bad tend to eat better during the week than they do on the weekends. So I'll tell people they take it Friday, Saturday, and Sunday, or Friday and Saturday. Take your 2 doses on Friday and Saturday, and that's it.
Got it.
Transient organisms, they live in your digestive tract for about 21 to 28 days. And so if you're taking them weekly, you're still providing a continual basis, you're providing a continual dose of it. You're getting the immune modulating benefits and the competitive exclusion benefits on a weekly basis, because you don't need them on a daily basis. So that's how we address the maintenance dosing.
Thank you.
Mm-hmm.
All right, in a minute, we're going to bring up David. I just want to let you guys know, because Peggy seems very concerned that we're skipping you, Peggy. Peggy, we're not skipping you. The system puts them all in order, fall in the order. David's ahead of you, and then you're up, Peggy. And for all those that don't get their questions answered, I want you to know that Tom gracefully said he will let you email him at the end of this as well. You can email him. But just so you know, we're fair here. We take care of you. The system tells us the order they come in. So that's how we're doing it. I don't know what you're seeing on your screen, but you got to trust us on this one. David Stone. Nice to have David back in the room. David, you should have microphone rights.
I do. Thank you. I think what happens is your own name goes to the top of the list. So it looks as if you're next, but it's just serving yourselves.
You just got to trust the team back here that we do really care for you guys, and we got your best interests at heart without destroying ourselves.
Yeah, so I think it's a simple question. You spoke about zinc dosages, but could you talk about what you might suggest as a regular maintenance dose?
So I'm using, as the preventative maintenance type dosing, I'm using between 15 and 30 milligrams a day. I would say that 30 milligrams for prevention is my high point. And so if I feel like there may have been some underlying deficiency, then I'll go with that. If I know they've been on zinc for a while, then I may just keep them at the lower end of that. But I think we're safe. I think we're safe in that zone. I don't think we will create any disturbances in the other minerals. So I feel good about that. Like I said, though, in therapeutic, how do we manage what the therapeutic dose is once somebody's got the virus? I know, like with vitamin C, you go to bowel tolerance, right? That's pretty simple for anybody to do.
Right.
I'm not sure that smell tolerance is something that you do. Like keep taking zinc until your sense of smell comes back. So I think there's smarter people than me that can chime in on that and give a better answer to that. But I just don't think we know yet. And maybe some of the frontline people have a better sense of what that therapeutic dose is. I know it's critical, but I'm concerned with 150 milligrams of zinc a day and the side effects of that.
Right. Okay. Thank you.
You're welcome.
Thank you. Peggy. All right.
Yes.
Peggy.
Okay, is my microphone off?
Yep.
You're off.
It is. Okay, so literally, I saw a patient right before this and went into this presentation, which is great. I'm a psychiatrist in quarantine, so I'm not a internist or dealing with the whole body. But she's an elderly woman who has, over the past week and a half, broken out with total body itching. It's not a medication. And just when I was seeing her over the video, she has had a emergence of round spots, and they look like bruises, but they're smaller. And I'm wondering, is that the iron? In other words, you were talking about the hemoglobin is kicked off. Is that how it presents?
It can, yeah. It
So
can.
I just need to call her and tell her to.
I mean, was she diagnosed with coronavirus?
No, she has an incompetent. I don't live in an area where there are people on top of it. Anything. Okay. Thank you. Thank you very much. That's all.
Yep, you're welcome.
Thank you, Peggy, as well. All right. Next is F.
Make sure that she gets that patient on vitamin C. That's if that is due to the iron overload in her bloodstream, let's get her on some liposomal vitamin C right away. IV if you can. Sorry, Lauren, go ahead.
Oh, that was great. That was added on question. And now we got F. Go ahead.
Hi, Dr. Skip here. Note to Peggy, the discoloration in the toes is also noted in some of the COVID patients, and it's probably from the heme. Okay, so my question, which I already had put on there, but I actually have two. One is, other than glutathione, wouldn't NAC actually almost be faster than glutathione?
For sure, yes. NAC is a good glutathione precursor, and it is an easier way to get it in, and it's a good antioxidant for the lungs. So
okay,
yeah.
And then my other question is, what can be done to either inhibit or block or slow down the dissociation of the heme out of the porphyrin ring, and that was where we lose the iron?
Yeah, I think there might be a Nobel Prize in it if I knew that. You know what? I've heard some conversations. I think they're simplistic explanations for our linear brains to understand what's happening. All I know is that the iron gets kicked off in the process of the virus getting a hold of the red blood cell. The actual mechanism and what we can do to keep it there, it looks like the only thing that's possible is to beat down the viral load. It doesn't look like we can have a step where we are still managing the virus, but we've somehow figured out how to keep the iron in its position. I don't think that that's feasible, but I'm obviously, like I said at the beginning, I'm very open to any new thing. And if, standing on your head means that the iron stays in on the red blood cell and prevents the spilling of iron, then I'll be recommending everybody stand on their head. But I think, the process really at this point is get rid of the virus and deal with the iron overload so the iron itself doesn't become a problem.
Okay, thank you. The only response I found from someone else is the talk was mostly using ascorbic acid versus the IV sodium ascorbate.
Right.
And they went through the whole biochemical process that if you can have enough antioxidant concentrated enough so that the actual iron fluctuating between the +2, +3 can get reversed back, it may not dissociate. I don't know. I'm like you. I could not figure out the mechanism how it was doing that.
Yeah.
All right. Thanks.
Yep. My pleasure.
All right. Next up is going to be Anne. Anne, you should have mic rights.
This Anne? Okay, great. Yeah, by a strange coincidence, I was just before this in a webinar with Kieran about this, basically the same presentation.
We're everywhere.
It was very cool. And keep meaning to try it myself. But what I'm wondering is, in the interest of how people generally tend to dose, obviously this is for a chronic issue and start ASAP, but supposing one were to start such a protocol just as one starts to get sick with, say, corona, do you think it would still have a good effect? And I have one more question after that.
So I don't, ask that again. I'm not sure I understand your question. That if they get it, that they can start at the full dose right away and just not have to do the.
Yeah, obviously we should all maybe start it right away.
Yeah.
And many people do, to deal with the
You're
inflammation.
only risking some discomfort, right? So that's the only thing you're risking. So if you take 2 capsules and you get some intense cramping and you don't want to live with it, you can always back right down on it. I had probably close to 125 patients on the product before I saw anything negative, right? So I went a long time. I just given 2 to everybody. I didn't think there was anything. And then I shut my mouth off and said, oh yeah, there's no problems with this. And then the next 3 people that came in my office wanted to kill me. I think that you have to weigh the risk versus the reward, and so if somebody's got the virus, they haven't taken the product, yeah, I would get them on the full load of all 3 of the products in the total gut restoration and deal with, a little bit of loose stool, a little bit of diarrhea, when it comes. But here's the thing, the virus might be causing that. So you don't even know.
Exactly. But my question was, supposing one did not start such a nice protocol until one already started to feel sick from the virus, say, oh my gosh, I've got COVID. I feel like and they started it right then. Would they still be able to expect some kind of a positive effect? Or is it really too late? Should they really be building up about a month in advance?
Hey, the sooner you get to it, the better, but it's never too late. If somebody called me right now and said, my mom's on a ventilator and, what can you do? I'd be saying, let's try to control it. Let's, can we get any supplements in her? I would start right away with all of these tools, no matter what level the patient's at. But if you're asking me, it's like, we go to the infertility shows here, right? It's like, if I'm going to talk, I don't want to talk to a pregnant woman. I want to talk to her 6 months before she gets pregnant. Mm-hmm. I don't want to talk to a coronavirus patient. I want to talk to them 6 months before they get the virus, right? If I had my choice, I'd like to be involved then. But I don't think that it's counterproductive or counterintuitive to give it to someone if they've never taken it, because it will be part of the control of at least the cytokines that are coming from their digestion and the meals they eat.
Okay, my other question was, are you able to ship to foreign countries outside the United States?
You can be specific and I can let you know. What country?
Let's say Europe, or particularly Mexico, for example.
We have a distributor in Mexico. We can put you in touch with them. We are going through EU approval right now. The one of the strains in Megaspore wasn't on the QPS, and so that's going to take about 2 years. But we do have a distributor in the UK, and he does provide product to people in the EU, and we do drop ship straight from the US. It's a little bit cheaper to get it from the UK, though, to be honest.
Right. Okay. Thank you.
You're welcome.
All right. Next up is going to be Andrea. Just give me a second here, Andrea. I didn't press the button correctly yet for you.
Am I unmuted, Dale?
You are.
Perfect. Lauren and Tom, I just want to say thank you so much. It was because of Lauren that I brought this into my practice about 2 years ago. And right now, all of my high risk older patients who I would want to have on Megaspore are on Megaspore.
Love it.
Yeah. So what you just said was really, really relevant. And I really credit Lauren for bringing you to this audience. And I have had nothing but phenomenal success with it. So I encourage everybody who's never had any experience with this to jump in. I also really appreciate everything you shared. Very informative, because took a little while for you guys to pull things together, and Trish is doing an amazing job of putting resources together. So just know that if you haven't tried this before, anyone else is listening, there's great resources that Tom has put together. My question has to do more with a product you didn't mention, so I apologize for adding one more layer of complexity to this talk. But there was some mention that Kiran had alluded to in terms of the IgG 2000. So in terms of that inflammatory response, because I've already gotten familiar with the Megaspore and not as familiar with the IgG 2000, Can you talk a little bit about how that could help with the inflammatory response that we're specifically seeing here with COVID? And then I have one more question after you answer that.
Okay. So the IgG, the serum bovine IgG is the main ingredient that is in the mucosal repair product. And it also is a standalone. And so what the serum bovine IgG, what it does is it binds to the LPS in your gut, and it prevents the LPS from spilling into your bloodstream. So it works kind of like a charcoal would work. The only thing is that where charcoal just binds to everything, the IgG specifically binds to specific poisons in the GI tract. And so it's very effective at reducing the load of toxins that might make their way to the leaky gut, to the holes in the tight junctions. And so it's very effective for that. I take between 8 and 12 IgG a day. I find that my digestion, my immune system functions so much better since I started taking that product. It's unique because I was a big colostrum guy for a long time. And I love colostrum, but what you loved about it was its ability to produce, to give people the IgGs to neutralize the poisons in their GI tract. What I didn't like about colostrum was the acceptable amounts of pus that were in it, and then the inconsistency in how much IgG you were delivering with each dose. So the serum bovine IgG, it's first of all, it's a lot more than the colostrum, but it's pharmaceutical dose. It's the same amount with every dose, and it used as what would be 5 grams of it is a drug. It's called Entergam, and it's used for inflammatory bowel disease. So the same ingredient is sold as a drug at a very high dose, and it's sold as a supplement at a lower dose. So for me, when I first started using it, I was using it like colostrum. And it was kind of like use a lot of it if the patient's got an inflammatory condition or inflammatory bowel disease specifically. But anybody else, you need a lot less of it. And so what I found through my own experimentation with myself and with patients was that that's not necessarily true, that the more you take, the more changes you see to the microbiome, to the immune system, and just general health by itself. So it's a phenomenal product. I can't say enough about it. The spores had the biggest impact for my health, but the IgG is a close second to that. And I would hate to not have one or the other. When I travel, those are my 2 go-tos. So that, then you said you had a second question?
Yeah, my second question has to do with a thank you, which is you guys have set up a system that very much respects the patient practitioner relationship. So you have really trusted the community of professionals, and you guys spent a lot of time educating us, but then you turn around and have protected where people can get this from. So in terms of where it's sold, with being in a shelter-in-place situation, your affiliate program is generous in that it does give a 30% commission compared to other affiliate programs that only do 20%. But the thing I'm struggling with is it doesn't protect that patient-practitioner relationship. So I'm just wondering if there's any plan to set up a system where you control whether or not the patient gets more and how many they order. Because I've had some patients who said, oh, well, I'm going to get 2 bottles this month. And when I ask them, they say, oh yeah, well, I was talking with, my brother, my cousin, my neighbor, and they want to give it a try. And so I'm really intentional about saying it's really valuable that they understand they need to kind of progress up the dose potentially so that there is no negative or adverse response, as you talked about. And so with the affiliate program, I haven't been as happy with the way that can kind of break that relationship between the practitioner and the patient. And I'm wondering if I could put that directly to you.
Yeah.
If something could be done in terms of us being able to prescribe, and then that triggers an email, and then the patients can only get what's prescribed.
I agree with you, and
Thank you.
I hate it too. What I would say is that it's a work in progress.
Okay.
That we're always monitoring things. That if doctors are trying to do things that we don't approve of, we're trying to monitor that, and we're trying to improve the experience for our physicians. You're like a sales rep for me, right? And so
Mhm.
I want to do right by you. And so what I would say is the short answer is I'm working on it.
Okay.
I do believe a solution is out there. And I will continue to do that because I remember being in your position and I didn't like being treated that way. And so I will do my best to fix that for you.
It has been a product that I have felt very, very comfortable bringing into my practice for that very reason,
Right.
because it brings my clients back to me. And it's not so much about control, because I want everybody to have your products, but it does at least
Andrea,
honor the investment.
I'm going to just, because we only have a few minutes left, and some of this is logistics, which you can chat with Tom offline as well, because I really want to get to the clinical aspect of this. But I thank you for your questions, by the way. I appreciate that, and your appreciation for what we're offering here. Really educational. Next up, because we got, I think, maybe time for one or two more here. So we got Diane. All right, so Diane is up, I believe, next.
Okay, thank you. I'm just wondering how this system construct might relate to the hypercoagulable blood states that are basically causing the multi-system failure in the COVID patients that are dying.
Right. That's your red blood cell issue there at its best. That's the iron excess in the bloodstream and the red blood cells that aren't carrying oxygen and then clumping and creating stress in the circulatory system.
Okay, thank you.
Yeah, no problem. That's vitamin C. That's why you need IV vitamin C. Those people need it more. When you see somebody with that, when they're at that stage, like stick a needle in their arm every couple hours and pump 50 grams of vitamin C in.
All right, Laura, you'll be our last question.
Okay, so it's a follow-on to that one, actually. So I am a carrier for hemochromatosis.
Yeah.
I have high serum ferritin levels as kind of an acute phase reactor.
Yeah.
So the treatment for that is like phlebotomy, just go get some blood drawn off.
Right.
And I just had labs done recently. I was going to go and donate like double red just to get it off. I missed the first part of your talk, so I might have missed something, but what would you recommend?
You got to be careful with the vitamin C, right? That's a big thing for you. Beyond that.
And how so? What do you mean?
Well, too much vitamin C can be problematic for you. So like if you were going to go to have an IV, they'd want to run some blood work to make sure that things were in line so that they didn't worsen the situation. And so I think that if you're giving blood and you're doing it regularly, oral vitamin C for prevention should be no problem, especially if you're using liposomal. But if you're jumping in and looking at treating with high doses or treating with IV, you need to see a practitioner who's skilled with this, has done it before, and knows what tests to run to monitor your ferritin levels.
Okay, great, thanks.
Yeah.
All right, I want to again thank you, Tom, for putting together a great presentation. So check out the Microbiome Labs website. There's been questions about distributors, so go to their website for the distributors. They got resources. You want to read more research, you want to see more videos, check out the website. They got a lot of stuff on prevention and treatments. And so public practitioner, regardless, check that out. Tom, thank you again for putting together this presentation. Thank you as well. It was just so neat. As I mentioned at the beginning, I called up Tom saying, "Hey, IFS is canceled, man. I got to give you your money back. Just give me, give me a little bit of time. I got to undo this thing. This is a huge undoing." He goes, "I don't want my money back." And I just said, "Well, I'm going to give you your money back. I got to give you some value." And then we said, we're doing these webinar series, and we out about this whole gut stuff. So I said, "Why don't you do your lecture. I was going to ask you to do it anyhow, but if you want to use your money that way, go for it. And so this is what we worked out. So thanks, Tom, for that. Stand up guy, appreciate it. Thank you guys for your great questions. The replay for this will be at healthyseminars.com/the Microbiome Labs link. So check that out. You can also get to there through our resources link, healthyseminars.com/resources. You can see all the upcoming free resources we have, as well as CEU content for practitioners. And you can get links to replays like this. So any last words, Tom, before we jump off and get back to our busy day?
Yeah, I just want to say thank you. Thanks for all you do, including this, but appreciate it. Appreciate supporting you. I'll just say my email's tom@microbiomelabs.com. So if you guys didn't get your questions answered, or if something else comes up, just shoot me an email and I'll get to it. If I don't answer you in 24 hours or so, hit it again, because I get about 300-400 emails a day. So do that. But happy to spend some time with you guys today, and thanks for having me. And
let's open the mics. This is what we do at the end of these. So for our community, unity, immunity, everybody give your love and appreciation to Dr. Thomas Bayne for this lovely lecture.
Thank you very much.
Thank you, Tom. Wonderful talk. Really great.
So much. That was awesome.
Everybody.
I
don't like Al Gore, but I guess he does some okay stuff now. But I mean, you look at the stream, and I think that
Thank you, Lauren.
raise is exactly what
Thank you so much.
office is going to look like.